Gentlemen, dear colleagues, thank you very much for the invitation. It's a pleasure to present today this topic in 15 minutes about heart and liver cirrhosis. Actually, you can understand this title in two different ways. First of all, liver disease such as liver cirrhosis may affect the heart and the whole cardiovascular system. But conversely, heart dysfunction, heart failure, chronic or acute, especially right heart failure, may also affect the liver, leading to complications such as cardiac cirrhosis. I will today only concentrate on the first type of interaction because the second one will be discussed here in Interlaken on Friday. So let me start with a short clinical vignette of a patient that we recently evaluated in Geneva. This is a 66-year-old lady suffering from alcoholic liver cirrhosis, child C, complicated by hepatic encephalopathy and esophageal varices and rectal varices with a recent episode of bleeding a couple of days before presentation. She also has a type 2 diabetes. She was admitted about 6 weeks ago for progressive dyspnea, functional class 3, and progressive lower limb edema. On physical examination, blood pressure was 105/56, heart rate 66 beats per minute. There was an elevated jugular venous pressure at 14 centimeters of water. There was systolic, mid-systolic ejection murmur, and bilateral basal pulmonary rales. There was also bilateral pitting edema to the thighs and clear evidence of ascites. This is a lab test of this patient showing a severe anemia at 77 grams per liter, hyponatremia, renal failure, and elevated liver function test. Finally, there was also an elevated BNP level at 995 nanogram per liter. I show you here the EKG of this patient showing a sinus rhythm at 62 beats per minute, a surprisingly low heart rate for a patient that is severely anemic. And you can also notice here microvoltage of the QRS. If you look carefully at the EKG, you also notice a prolonged QT at 460 milliseconds. I show you here now the transthoracic echocardiogram of this patient, where you can appreciate here on the lower video the apical four-chamber view with a mild enlargement of all 4 cardiac chambers, and you can also notice a completely normal ejection fraction that was calculated at 64%. And finally, I show you here the diastolic function parameters of this patient. You see on the upper part the mitral inflow pulse Doppler, and in the lower part you see the tissue Doppler of the septal mitral annulus. The E/E' ratio was at 16.6 in this patient, clearly suggesting elevated left ventricular filling pressures due to diastolic dysfunction. So to summarize, a patient with a clear picture of heart failure, normal ejection fraction, elevated BNP, prolonged QT, and a surprisingly low heart rate in a patient with a severe anemia. So this patient presents several features of a syndrome that has been named cirrhotic cardiomyopathy, and a syndrome that has been defined in 2005 as cardiac dysfunction in patients with cirrhosis, characterized by impaired contractile responsiveness to stress and or altered diastolic relaxation with electrophysiological abnormalities in the absence of other known cardiac disease. As you can see, the definition is rather vague and there is no strict diagnostic criteria. It occurs in about half of patients with cirrhosis, and it is independent of the etiology of liver disease. These are the main features that have been described in cirrhotic cardiomyopathy. In this slide, I have divided them in three groups, structural changes, including enlarged cardiac chambers, especially the left atrium, increased myocardial mass. There are also electrophysiological changes, such as prolonged QT interval and abnormal chronotropic response. Finally, functional changes, impaired increased cardiac output with exercise, sometimes but rarely a low resting LVEF below 55%, more frequently diastolic dysfunction, and elevated biomarkers of heart failure. So in the next slides, I would like to give you an overview of the pathophysiology of this syndrome and to describe some of the most prominent features of the syndrome. So hemodynamics in cirrhosis is not new. You see here a paper dating back 60 years ago from Kowalski and Abelman from Boston, and they clearly demonstrated that the cardiac index in patients with liver disease is higher than in normal controls. By the way, you can observe here that North American physicians, and it is still the case now, often use the term Lennox cirrhosis. And as mentioned by Dr. Senela before, Lennox was the first to coin the term cirrhosis. Actually, cirrhosis comes from the Greek, kyros, meaning tawny in English, or jaunâtre in French, referring to the color of the liver in patients with cirrhosis. So now how can we explain this increased cardiac output in cirrhosis? So we know that liver cirrhosis may lead to increased intrahepatic vascular resistance because of fibrosis, regeneration nodules. And this increase in vascular resistance will lead to portal hypertension. In portal hypertension, there is a release and a decreased degradation of several vasodilators that are listed here on the slide. And this will lead finally to splanchnic vasodilation. And the consequences of splanchnic vasodilation is a decreased global systemic vascular resistance and also a blood pooling in the splanchnic bed. And this will lead to the hyperdynamic circulation and also to what we call central hypovolemia or effective hypovolemia. And this in turn will stimulate baroreceptors, volume receptors, and this will increase the different neurohormonal system that you all know well, the renin-angiotensin-aldosterone system, the sympathetic nervous system, and there will be also an increase of the antidiuretic hormone. So altogether, these factors will participate in the pathophysiology of cirrhotic cardiomyopathy. Now, what about structural changes? According to an autopsy study in 135 patients with cirrhosis, the main cardiac abnormalities were left ventricular and right ventricular dilatation, and there was also left ventricular hypertrophy. These changes were present in almost 1/3 of the patients. Echo and MR studies showed conflicting results, but left atrial dilatation and mild left ventricular hypertrophy were the most often reported changes in this population. These changes are probably reflecting a combination of mechanical overload due to hyperdynamic circulation and to neurohormonal activation. What about the impaired cardiac response to exercise? In this study, this is really clear that during exercise, cirrhotic patients cannot reach a very high peak heart rate. You see here a peak heart rate of about 60% of the maximal predicted value. And the same is true below for ejection fraction. This patient during exercise could not increase their ejection fraction compared to normal controls, even if resting LVEF was normal or even supranormal at rest. So the consequence of that is that cardiac index cannot be increased as much in patients with cirrhosis compared to normal control. So how can we explain this impaired response to exercise? I show you here a cardiomyocyte, and according to animal models of cirrhosis, there are three main mechanisms that explain this impaired cardiac response to exercise. The first one is a downregulation and a desensitivation of beta receptors in the cardiomyocyte. The second one is a reduced expression of L-type calcium channels. And the third one is the increase of several mediators such as cytokines, nitric oxide, carbon monoxide, or endocannabinoids. And all these substances will have a negative impact on the intracellular signaling for contraction. So altogether, the consequence of that is that the heart of these patients has little chronotropic and inotropic reserve. And there is an intolerance to all conditions requiring a further increase of cardiac output, such as anemia, like in our patient, or sepsis, or invasive interventions. And of course, these conditions may precipitate decompensation of heart failure. I come now to diastolic dysfunction, which is probably the most pronounced functional alteration seen in cirrhotic cardiomyopathy. It is due to a combination of myocardial hypertrophy, fibrosis due to increased aldosterone levels, and subendothelial edema. Its prevalence is reported from 45 to 56%. Very common is also the prolonged QT interval, with the prevalence over 60% in advanced liver cirrhosis. The pathophysiology of long QT is not clear. Portal hypertension and portal systemic shunts are necessary, but endotoxins, cytokines, and increased sympathetic nervous system activity also play a role. The clinical relevance of long QT is not clear in this situation. There are descriptions of rare ventricular arrhythmias, but there is a debated effect on survival. Obviously, drugs affecting the QT should be avoided in this context. Now, is it serious to have cirrhotic cardiomyopathy when you have a liver cirrhosis? Actually, we do not really know. There are not much data on prognosis in these patients. I show you here two small studies. The first one here in 24 patients with cirrhosis and ascites. And there was in this study a clear association of low cardiac index between 1.5 and mortality on the left panel here. And there was also an association between a low cardiac index and low GFR. And actually more and more data now show that there is probably a close link between cirrhotic cardiomyopathy and the hepatorenal syndrome. I show you here a second study where diastolic dysfunction expressed as a E/A ratio of 1 or less was associated on the left figure here with ascites persistent after TIPS. TIPS means transjugular intrahepatic portosystemic shunt. So predictor of ascites persistence, but also predictor of survival in this population. So I come now to my conclusions. Cirrhotic cardiomyopathy is a frequent syndrome occurring in almost half of patients with advanced liver cirrhosis. There are no strict diagnostic criteria, but impaired cardiac response to stress, LV diastolic dysfunction, and prolonged QT are the most prominent features. The clinical relevance of this syndrome is not well established yet, but these patients do not tolerate any conditions requiring a further increase of cardiac output. There is no specific therapy for this syndrome, which is almost completely reversible after liver transplantation. I thank you for your attention.